to everyone, and welcome to this session. The title of the session is Updated WHO Guidelines on the Management of Tuberculosis in Children and Adolescents, the Role of Chest Radiography. This session is jointly organized by the World Health Organization, the International Society of Radiology, and the World Federation of Pediatric Imaging. I will be chairing this session with my two co-chairs, Donald Fresh, as well as Joanna Kasnia-Brown from the International Society of Radiology and the World Federation of Pediatric Imaging, respectively. My name is Farhana Mavunga. I head the unit of vulnerable populations, communities, and comorbidities in the Global Tuberculosis Program. And this is the unit under which child and adolescent TB are addressed. I am a medical doctor and a public health practitioner, and previously worked as a national TB program manager for about 10 years. And have also worked in the regional office at WHO in the WHO regional office for Africa before I joined HQ. Professor Donald Fresh is a medical doctor who is a pediatric radiologist and the John Strauben Professor of Radiology at Duke University Medical Center. His research interests are predominantly involved with pediatric body CT, image quality, and radiation management and risk communication in medical imaging. Amongst his roles, he is the chair of the Image Gently Alliance. He's also a co-chair of the International Society of Radiology Quality and Safety Alliance, and works internationally with WHO and the International Atomic Energy Agency with radiation protection projects in medical imaging. My other co-chair is Dr. Joanna Kasnia-Brown, who is a senior consultant radiologist at the University of Bristol in the United Kingdom. Her work includes pediatric and oncology imaging with special interest in pediatric MRI and functional cancer imaging. Joanna is the president of the World Federation of Pediatric Imaging and the current chair of Outreach Committee of the European Society of Pediatric Radiology. She has been actively involved in many international projects in Africa, Asia, Europe, as a radiology expert and senior consultant for the UN, WHO, and the International Atomic Energy Agency. Dear participants, I kindly invite you at any point during this session to post your questions in the Q&A box and not in the chat. And could you please also indicate to whom the question is directed, so which speaker you would like to respond. As we may not be able to attend to all the questions during the session, we kindly request you to also indicate your email address when you post a question. In case we are not able to respond during the session, we could follow up with a response in the next day or two. We now move on to the opening session, where I'm going to invite my director, Dr. Tereza Kasaeva, the director of the World Health Organization's Global Tuberculosis Program. She has been leading the work on norms, policies, and standards on TB prevention and care, and also technical support to countries, including through the 3-level WHO TB Technical Expert Network, as well as monitoring the global TB epidemic, promoting research and strengthening political and multi-sectoral engagement, accountability, and advocacy to end TB since 2018. Dr. Kasaeva has more than 28 years of experience in public health and is and in leading innovative efforts for socially significant diseases, including TB. Dr. Kasaeva, the floor is yours.
So thank you very much, Farai. Good morning, good afternoon, good evening, dear colleagues. Once again, on behalf of the Global Tuberculosis Program of the World Health Organization, I would like to warmly welcome you to this World TB Day Scientific Symposium, joint event organized with our colleagues and friends from the International Society, WHO International Society of Radiology, and the World Federation of Pediatric Imaging. This day, traditionally 24th of March, we are trying jointly to raise awareness and understanding about TB, preventable, curable disease, but still one of the top infectious disease killers. Colleagues, I hope you can hear and see me. On World TB Day, we aim to discuss and generate much needed actions to prevent and address tuberculosis, which has, as we all know, a devastating social and economic impact. Of course, we are also commemorating those millions who lost their lives to TB, preventable and curable disease, and still suffering from it all worldwide. TB affects everyone, but children and adolescents are particularly vulnerable. WHO estimates that 1.1 million children and young adolescents become ill with tuberculosis every year, and almost half of them aged below 5 years. Unfortunately, according to our latest global tuberculosis report, less than half of these children and adolescents are diagnosed and reported, which means that there is a large gap in detection and in access. It's reflected clearly in the numbers of also children with the most severe form of tuberculosis, drug-resistant TB, where we had a target to detect at least 115,000 children between 2018 and 2022, in line with the United Nations high-level meeting on TB targets. But by 2020, only 11% of these children had been detected. The theme of this year World TB Day is Invest to End TB, Save Lives. This is appropriate, reflecting our essential needs, very much needed, and we can see also huge reversal of gains in the TB response caused by COVID-19 pandemic. We could see significant drops in TB notification, at least 18%. 18% of people were not diagnosed, and it means that they were not put on treatment. In addition, it's estimated that over 200,000 children died due to TB, and most of these children did not access TB care. Unfortunately, access to TB services for children has been disproportionately, as we could see, impacted by COVID-19 pandemic, resulting in decline in TB notification of 24% for the age group under 15 years. Actions to mitigate and reverse these impacts for all populations, including children, are urgently needed, as well as the impact of COVID-19, ongoing conflicts in Eastern Europe, the African region, and the Middle East, with movement of people out of these conflict zones also put progress at risk and increases vulnerability to TB. As we well know, many of these populations are children and young children, and we are all following with deep concerns the ongoing conflict in Eastern Europe, in Ukraine, and working closely with our colleagues from regional and country office, WHO country and regional offices, and we can see that more than 3.5 million people moving from Ukraine to the neighboring countries, almost 50% are children. And we also know that Ukraine is one of the high TB burden country with drug-resistant TB burden. It means that we should do our best to provide continuation of care of those affected with tuberculosis, and with the prioritization of children, of course. To facilitate prevention, management, and care of TB in children and adolescents in line with the latest evidence, WHO reviewed its recommendations on the management of TB in children and adolescents, and updated guidelines resulting from this process were launched by the Global TB Program on Monday this week. Guidelines are accompanied by an operational handbook which provides clear guidance and recommendations to the countries and technical partners how to implement these updated and much more effective approaches. The new recommendations span the TB cascade of care, from diagnostic approaches to treatment of both drug-susceptible and drug-resistant TB, to models of care to optimize TB prevention and TB detection and care efforts. Of special relevance to the webinar today are new recommendations on a shorter treatment regimens to treat children with non-severe TB. And very good news are that now we will be able to shorten this treatment from 6 months to 4 months for this group, again based on evidence. And a recommendation on use of treatment decision algorithm using a combination of chest radiography as well as signs and symptoms of TB and WHO recommended diagnostic tests. I hope that in this symposium we'll hear more about the role of chest radiography in detecting TB among children, as well as in determining the duration of treatment and other important comments, advice, and decisions on the next steps of our collaboration, and with a focus on the implementation of these new guidelines and approaches. When fully implemented, both of these recommendations should result in the detection of more children with TB and the provision of shorter treatment, allowing children to return to school earlier, resume their normal lives, reduce costs for children, burden for families, and on healthcare systems. Referring again to our global TB report, we can see that almost 50% of all TB patients are still facing globally catastrophic costs due to TB or due to its treatment. We hope that we will make a significant contribution to minimize this burden if the guidelines will be uptaken fast and implemented. Today, we'll also discuss the challenges and successes in accessing chest radiography from experts working in the field and from those representing professional associations. These perspectives will be important as we seek to adopt and roll out the new WHO recommendations. In close collaboration with our technical partners and donors, WHO will now work to guide to assist countries to rapidly adopt these recommendations to ensure that children, adolescents, and their families can benefit from them as soon as possible. This is a part of WHO aim and mandate to end TB in children and adolescents by the year 2030. And ideally, it will be good to do it even earlier. This is fully aligned with our NTB strategy targets and principle, as well as with the sustainable development goals and the UN high-level meeting on TB targets and commitments. We look forward to discussing these issues, the best approaches, how to address our challenges and how to transform our challenges into opportunities. And we are extremely happy to have this highly professional, dedicated, and audience who is passionate about providing better diagnosis and treatment to children, and of course followed by better treatment outcomes. I would like to wish all of us a very successful scientific symposium with the constructive discussions, and looking forward to hear from you your vision how we can optimize management of TB in children and adolescents. Thank you very much.
Well, thank you, Dr. Kasaeva, for that compelling welcome to this symposium. And I'm sure that the following material will both be provocative and engaging as we proceed here. I would like to introduce the first of the two major sessions here, setting the scene. And as you can see here, we have 4 expert panelists, and I'd like to take just a few minutes to introduce each of these. The first is Dr. Sabine Verkuijl from the Global Tuberculosis Program, World Health Organization. Dr. Verkuijl is a family physician working as a medical officer on child and adolescent TB in the TB Vulnerable Populations, Communities and Comorbidities Unit of the Global Tuberculosis Program at the World Health Organization. Prior to this, she did consultancy work for UNICEF on integration of childhood TB into maternal and child health programs, was a lecturer on a postgraduate diploma on TB and HIV clinical management for the University of Cape Town, and TB and HIV technical advisor for the International Center for AIDS Care and Treatment Programs in South Africa. She started her career in international public health as a medical officer in a rural hospital in the Eastern Cape Province in South Africa. The second talk will be given by Professor Steve Graham from the International Union Against Tuberculosis and Lung Disease. Dr. Graham is a professor of international child health with the University of Melbourne and a pediatrician with clinical and research experience in TB in African and Asia Pacific regions. He co-chaired the WHO guidelines, the World Health Organization Guidelines Development Group for the updated consolidated guidelines on child and adolescent TB. He is also a child TB consultant with the union and contributed to the original from 2003 and more recent editions of the union's chest X-ray Diagnostic Atlas. The third speaker, the third panelist, is Dr. Anna Turkova. She is a research clinician at the Medical Research Council Clinical Trial Unit at University College London and an honorary consultant pediatrician at Great Ormond Street Hospital. Anna has been working with PENTA, a pediatrician European network for treating HIV and other infectious diseases, since 2011. She is a member of the WHO HIV Guidelines Development Group and WHO-led Pediatric Antiretroviral Working Group. She is a trial physician in several large international pediatric HIV and TB trials, including a recently published SHINE trial, which she will discuss. And finally, our last panelist is Dr. Megan Palmer, also a pediatrician and a clinical researcher at the Desmond Tutu TB Center in Cape Town, South Africa. She has worked in the field of pediatric TB clinical research for the last 8 years, focusing on diagnostics and more recently, TB treatment trials. She is currently a PhD candidate exploring data-driven approaches to the use of imaging to diagnose and manage pediatric TB. So I would like to now give the floor to Dr. Verkuijl.
Thank you very much. Good morning, good afternoon, good evening, everybody. Thanks for joining this webinar. I hope this, yes, thank you. You can go to the next slide straight away. So I'll be speaking about the updated WHO guidance on the management of TB in children and adolescents, and we'll cover the most important epidemiological data and the main programmatic gaps, and then provide an overview of the new recommendations, zooming into the role of chest radiography in diagnostic approaches and in assessing disease severity. Next slide, please. To start off, this slide shows the global burden estimates from the 2021 Global TB Report, presenting estimates for the year 2020. The estimated incidence of TB in children under 15 years is just under 1.1 million, and therefore children make up about 11% of the total incidence of just below 10 million. Overall deaths increased for the first time in years to 1.5 million, mainly as a result of the impact of the COVID pandemic. Mortality has been estimated at over 220,000 in children, which means that children make up 15% of all TB deaths, whereas they only make up 11% of the burden. The majority of deaths, as Dr. Kasaeva has already said, occur in young children under the age of 5, and the vast majority of children who died did not access TB treatment. Next slide, please. The COVID-19 pandemic has had a profound impact on TB services for children. And this graph illustrates the disproportionate impact on notifications in the different age groups already referred to by Dr. Kasaeva. The slide compares data for 2020 with 2019. And the data show that the impact was highest in the youngest children, with a drop of in notifications of 28% in the age group under 5, 21% in the age group between 5 and 14 years, compared to 18% in ages 15 years and over. Next slide. So we have large gaps in case detection as well as in preventing TB, and these need to be addressed as a matter of urgency. The overall case detection gap has widened last year. Case detection for all TB was about 37% in all children under 15 years, and only 28% in children under 5 years. This means that 72% of children under 5 are not diagnosed and or not reported. In addition, almost 2/3 of eligible children under 5 did not receive TPT, TB preventive treatment, and therefore run the risk of getting sick with TB. Next slide, please. So moving on to the development of the updated guidelines. WHO held a guideline development group meeting in May and June last year. The GDG reviewed evidence on a wide range of PICO questions covering diagnostic approaches, treatment of drug-susceptible TB, TB meningitis, and drug-resistant TB, as well as models of TB care. A rapid communication was published in August last year to flag the upcoming changes, and this week the full guidelines were published, along with an operational handbook which provides practical implementation guidance on the full cascade of care. Next slide. The target audience for both documents include national programs on TB, HIV, primary health care, and maternal and child health, as well as healthcare workers at various levels, the education sector, and various organizations involved in TB care or TB programmatic management. The objectives of both documents is to contribute to reductions in morbidity and mortality in children and adolescents in line with global targets in the Sustainable Development Goals, the End-TB Strategy, and the UN General Assembly High-Level Meeting on the Fight Against TB. The analytic framework used is the pathway of TB infection and disease in an individual child or adolescent, as you can see on the right of this slide, and the interface with and retention across sequential stages of care, which is also referred to as the cascade of care. Next slide. I'll give an overview of the new recommendations in the guidelines, and we'll zoom into the role of chest radiography for the diagnosis of TB in children, as well as for assessing severity of disease to determine duration of treatment. The first new recommendation is on the use of expert ultra on pediatric specimens There was already a recommendation on the use of expert MTB-RIF on sputum, nasopharyngeal aspirate, gastric aspirate, and stool, and one on the use of the expert ultra assay on sputum and nasopharyngeal aspirate. The GDG reviewed evidence on the use of ultra on gastric aspirate and stool, so the previous recommendation was updated to include these specimens. This means that both assays can be used or should be used as initial diagnostic test rather than smear microscopy and culture and phenotypic drug susceptibility testing on the full range of pediatric specimens. Next slide. Then we have an interim recommendation on the use of integrated treatment decision algorithms in children with presumptive TB who are attending healthcare facilities to make a decision to start TB treatment for pulmonary TB. This recommendation is valid for 2 years, after which new evidence will need to be reviewed. An important remark is to seek bacteriological confirmation whenever possible, in line with the recommendation on rapid diagnostics that we just covered. Next slide. The evidence reviewers, in collaboration with a subgroup of the GDG, developed 2 algorithms based on an individual patient database of diagnostic studies. 2 algorithms are presented in the operational handbook. Algorithm A, to use in settings with access to chest radiography, and algorithm B in settings without. And this slide shows the top part of the algorithms, which is actually the same for both A and B. The main characteristics are the inclusion of a triage step to stabilize or transfer children in need of urgent medical care. This is then followed by a step to assess risk for rapid disease progression, which determines the timing of the next steps in the algorithms. Children who are below 2 years, are living with HIV and or have severe acute malnutrition are regarded as high risk and continue with the next steps in the algorithm immediately. Children who are not regarded as high risk are first treated for the most likely non-TB condition. That is, for example, asthma, pneumonia, or malaria, and will only go to the next steps if there's no improvement after 1 to 2 weeks. The next step is to use molecular WHO-recommended rapid diagnostics on appropriate pediatric specimens and LF-LAM if the child is living with HIV. Next slide. This slide shows the bottom part of algorithm A, and the yellow block provides scores for clinical signs and symptoms, as well as chest X-ray features. And chest X-ray features include cavitation, enlarged lymph nodes, opacities, a miliary pattern, and pleural effusion. If the total score of signs and symptoms and chest X-ray features is more than 10, the child should be started on TB treatment. And it's important to note that the child can have the chest X-ray at any point in of time in the evaluation, and should the score based on signs and symptoms already be more than 10, treatment can be started while awaiting the chest X-ray result. Chest X-ray is highlighted as an important tool to determine disease severity, which is one of the 2 other assessments a child with a decision to start treatment should undergo. The other assessment is for risk factors for drug-resistant TB, so that appropriate second-line treatment can be started. The handbook contains detailed guidance and examples of scoring, as well as a printable job aid in one of the annexes. And an important note is that following an expert consultation on the classification of intrathoracic TB disease in children, intrathoracic lymph node TB is now classified as pulmonary TB and no longer as extrapulmonary TB in children aged below 10 years. Next slide. The next recommendation is on shortening the duration of treatment for children and adolescents between 3 months and 16 years of age with non-severe TB. And non-severe TB is defined as peripheral lymph node TB, intrathoracic lymph node TB without airway obstruction, uncomplicated TB pleural effusion, or pulsibacillary non-cavitary disease confined to one lobe of the lungs and without a miliary pattern. Children with more severe forms of TB should receive the standard 6-month treatment regimen or recommended treatment for severe forms of extrapulmonary TB. And this recommendation was informed by the SHINE trial. And in one of the next presentations by Dr. Anna Turkova, we will hear more details about the trial and its results. Next slide, please. The operational handbook provides practical guidance on assessing disease severity. And as indicated at the top of this slide, you see the definition of non-severe TB. And this is then applied to different settings with varying access to diagnostic tools. And the rationale behind this is that lack of access to these tools, including chest X-ray, should not be a barrier for children to access the shorter treatment. In settings with access to both chest X-ray and bacteriological testing, non-severe TB is based on the chest X-ray features as mentioned, and on expert MTB-RIF or ultra results that are negative, trace, low, or very low. The child should also have mild symptoms that do not require hospitalization. Then in settings without access to chest X-ray, the assessment is based on the expert results, if done, and the presence of mild symptoms. And then in settings without access to either of those, the assessment is based on the presence of isolated peripheral lymph node TB without involvement of other extrapulmonary sites, and then again, mild symptoms not requiring hospitalization. And mild symptoms have been defined in the operational handbook. Next slide. We also have a new recommendation on a 6-month intensive regimen for the treatment of TB meningitis, which may be used as an alternative to the standard 12-month treatment regimen. This regimen has been used in South Africa for many years. It's used for children and adolescents with bacteriologically confirmed or clinically diagnosed TB meningitis without suspicion or evidence of drug resistance. And of note, the operational handbook includes a dosing strategy for this regimen. Next slide. The last recommendation that covers treatment is on the use of bedaquiline in children under 6 and the laminate in children under 3 years who have multi-drug or rifampicin-resistant TB. Both medicines are now recommended in children of all ages. These are both conditional recommendations based on very low certainty evidence. Bedaquiline may be used as part of the shorter all-oral bedaquiline-containing regimen or as part of longer regimens, and the laminate may be used as part of longer regimens. So these new recommendations mean that it is now possible to build all oral regimens for children of all ages, including neonates. Countries are therefore encouraged to phase out injectables as these are no longer recommended. The operational handbook contains an updated dosing table expanding the lowest weight band to 3 kgs for all second-line drugs. Lastly, we have recommendations on models of TB care for case detection and the provision of TB preventive treatment. These recommendations cover decentralized and family-centered integrated models of care to deliver TB services. The recommendations are applicable to TB services along the full cascade of care with a focus on case detection and provision of TB preventive treatment. The recommendation on decentralized services refers to enhancing child and adolescent TB services at peripheral levels of the health system and closer to where children and their families live, not to replacing specialized pediatric TB services at higher levels of the health system. Family-centered integrated approaches are recommended as an additional option to standard services, for example, alongside specialized services that may have a limited level of integration with other programs or linkages to general health services. And it's important to recognize that family-centered care is a cross-cutting principle of childcare at all levels of the health system. I actually think the slide has not progressed. Sorry, I probably forgot to ask you to progress it. So this is the slide on models of care. You can go to the next one. So the consolidated guidelines bring together valid recommendations from other guidelines. And this slide provides an overview of the different WHO guideline documents from which relevant recommendations were sourced, including TB prevention and screening guidelines, the BCG position paper, guidelines on rapid diagnostics and treatment of drug-resistant and drug-susceptible TB, and some validated recommendations from the 2014 childhood TB guidelines, as well as HIV and nutrition guidelines. Next, please. And all guidelines and recommendations, along with operational handbooks and training materials, are in the process of being featured on the WHO TB knowledge sharing platform. And you can see the link to the platform in this slide. So this brings me to the end of my talk. If you go to the next slide, and I would like to thank colleagues from the WHO Global TB Program, including our director, Tereza Kasaeva, our unit head, Farhana Vunga, team lead, Kerri Viney, and colleagues Annemieke Brands and Tiziana Massini, as well as all the experts. And you can see in the guidelines and handbook, there's a long list of contributors to these documents. All the people who contributed to the development of the guidelines and the handbook, including the guideline development group, the external review groups, technical partners, funding partners, and many members of the Child and Adolescent TB Working Group. Thank you very much.
I would like to say a big thank you to Dr. Sabine Verkuijl for this very informative and excellent introduction to the new update of the WHO guidelines and the practical guidelines and the new algorithms that you presented. I'm sure that will be very helpful to many of us. And now I would like to introduce the second speaker, Professor Steve Graham, who will present the talk and share his thoughts on chest radiography in context, detect, treat, prevent TB in children. The floor is yours, Professor.
Yeah, thanks very much. And thanks for the invitation to speak at this important seminar and for following Sabine's excellent detailed introduction. It's my task to put chest X-ray in context. As a clinician, I hasten to say, not a radiologist. Next slide, please. We know that chest X-ray has limitations for diagnosis of TB in children, but still commonly used in the assessment of children with presumptive TB for diagnosis and treatment decisions, to define clinical classifications for reporting non-bacteriologically confirmed TB cases in research. It's routinely done at least in resource-rich low TB endemic settings to exclude active TB before initiating TB preventive treatment. And finally, it's often used as a sensitive screening tool for active case finding, at least in older adolescents and adults in TB endemic settings. I still remember as a young child in the 60s doing the 100-mile return car trip to a local town in rural Australia with my parents for them to be screened in the mobile chest X-ray van. And for children in TB endemic settings, accessibility remains an important challenge. But accuracy of interpretation, quality, sensitivity, and especially specificity, as well as confidence with chest X-ray reading by child health care workers, are all important limitations. Next slide. We know that child TB cases, most child TB cases occur in young children, and that pulmonary TB are the majority, and some forms of extrapulmonary TB are also diagnosed by chest X-ray, such as miliary TB, TB effusion, pericarditis, TB of thoracic spine. Next slide, please. Chest X-ray, along with most of the tools we still use, have been around a very long time and still used in the majority of children with presumptive TB. As mentioned, one of its main challenges in young children is low specificity of some of the parenchymal abnormalities. And I've often commonly taught to think TB when the parenchymal lung changes look worse than the child, different to, say, pneumococcal pneumonia, but I'm not sure that such an observation has been validated. Next slide. The newer diagnostics, such as XPERT, are an improvement on smear microscopy, but do not have as high a yield in children as in adults. So they certainly cannot rule out TB. Most cases still require clinical diagnosis. In research studies, the sensitivity of expert is around 35% and much lower often in programmatic practice, especially in outpatient settings. Next slide, please. There are important age-related features, and I thank James Seddon for this slide, to consider from infancy to adulthood, shown here diagrammatically. There's a high risk of disease in younger children, and in young children, high risk of severe disseminated disease. There's also an increasing risk in older adolescents. As Sabine highlighted, case detection is a particular challenge in young children, and common radiological abnormalities are often quite different in that age group compared to those seen in adolescents or adults. Intrathoracic lymphadenopathy is the commonest abnormality, but other radiological abnormalities are often non-specific or difficult to interpret. Next slide, please. This slide shows the mechanism of intrathoracic disease with lymph node enlargement, or the consequences of that inflammatory response. It may be isolated or it may be wide-ranging and sometimes complicated. Next slide. Next slide, please. Professor Robert Guy developed this atlas, no, previous slide, sorry. Professor Robert Guy developed this atlas for the Union about 20 years ago in recognition of the particular differences of radiological presentation in children and the particular challenges then particularly of lung disease in HIV-infected children. This atlas was developed with the underlying principle of improving health worker confidence to detect and treat TB in children, especially the most recognisable forms. Next slide. So chest X-ray is included as a step in most clinical management approaches, such as this example from the Union Desk Guide. Next slide. Or the more recently developed approach that Sabine has just highlighted, that is included in the WHO operational handbook, that includes some scoring for the most specific TB abnormalities. Work was led by Ken Gunasekera and James Seddon. Next slide, please. There are now more sensitive imaging methods for identifying pathology, including lymph node disease, such as CT or MRI imaging, but these are not usually available and are more expensive. Next slide. So we still rely on chest X-ray despite some uncertainty in its ability to detect perihilar lymphadenopathy. These examples are from evaluation of chest X-ray reading at Red Cross Hospital in Cape Town by very experienced paediatric radiologists. And the interpretation of AP and lateral chest X-ray was compared to CT chest as a reference standard. Sensitivity and specificity were low, and it's not a surprise that agreement, even intra-observer agreement, was moderate at best. Next slide, please. So just to finish, I want to spend a few minutes on other potential roles for imaging that will now get greater attention. Chest X-ray remains an important tool for community-wide screening and case finding, as recommended by WHO. It's more sensitive than symptom screen, consistently found in prevalence surveys, where around 1/3 of bacteriologically confirmed cases in adults do not report symptoms. There is a spectrum of disease and subclinical disease, but arguably this issue is more important when the focus of the intervention is on reducing transmission. Next slide, please. As for screening for disease in children, this is most commonly done as part of the contact screening, identifying contacts of all ages with prevalent disease as an important part of contact management, as is excluding active disease before providing preventive therapy. There's now greater focus on prevention than ever before, and some of that momentum is facilitated by having now a wider range of preventive treatment options that are shorter, safer, and more likely to be completed. Now that WHO guidelines include older HIV-negative children and adolescents to initiate TB preventive treatment if they are recent contacts and do not have disease, then the use of or need for chest X-ray in this context in resource-limited settings will increase. Next slide, please. This symptom-based approach to contact screening and management by age was published back in the first WHO guidance in 2006, and I'm happy to take responsibility. You'll see that the only child contacts likely to have a chest X-ray were those with symptoms as part of evaluation for disease. More recent research, such as from Indonesia, has validated the approach among well child contacts under 5. Perihilar adenopathy being the most commonly observed abnormality, but it was not common, and among 4 experienced readers, inter-observer agreement as to which X-ray had perihilar adenopathy was low. A similar symptom-based approach now has already been adopted for people living with HIV to receive TPT. Next slide. Now that we want to expand TPT to older children and adolescent contexts who are not HIV infected, there may be a greater need for chest X-ray to guide management. And here's an example building onto that previous approach. Next slide. And here is chest X-ray placed within the algorithm published this month in the Union Journal on Clinical Standards for TB Infection. So next slide, please. So this is the final slide. I've highlighted some of the challenges and limitations through the talk, and they're well recognized. And I'm sure that this list here is not exhaustive. It is timely to indicate, as many of you know, there are now more mobile, portable, lower dose methods to take a chest X-ray and have it read by a computer-assisted device informed by artificial intelligence. However, the promising findings of performance from studies in adults cannot necessarily be extrapolated to children, especially young children that usually have much less in the way of specific parenchymal changes. So need further validation, and Farhana will give some experience from Pakistan. Megan will expand more on some of the challenges listed and her perspective on training, and some of the others attending the call, such as James and Pierre-Yves, and effectiveness will be on the effectiveness of training will be valuable. Next slide, thank you. Thanks to all for listening, and thanks to my colleagues at the Union and WHO. And we will hear more from Megan now about the Union's updated atlas, which was launched today on World TB Day. Thank you very much.
I would like to say a big thank you to Professor Graham for joining us today and sharing his knowledge and experience with us. And especially important that it's after midnight in Melbourne, and we really appreciate you being here with us. And I'm sure that will be many questions as they are coming to the box that we will discuss it later with Professor Graham. And now I would like to introduce Dr. Anna Turkova, and she will share her experience and the overview of the SHINE trial with us and the role of the chest radiography. Yes, please.
Good afternoon, everyone. And I would like to thank the organizers for giving us this opportunity to overview the SHINE trial results and the role of chest radiography. I'm presenting on behalf of the SHINE trial team. Next slide, please. TB treatment shortening is one of priority research questions in the end of TB strategy. Shorter duration can improve treatment completion, reduce toxicity, and reduce costs. Historic adult trials showed that non-severe post-bacillary forms of disease could be treated with shorter duration of therapy, which was confirmed in post-hoc analysis of the recent TB treatment shortening adult trials. For the childhood TB, we know that the majority of children have non-severe TB, and therefore it's just logical that a shorter treatment would suit this group of patients. Next slide, please. The SHINE trial was the first large randomized controlled TB trial in children. Next, please. It was an open-label phase 3 non-inferiority RCT, and we determined whether 4 months of treatment would be as good as 6 months in children with smear-negative, non-severe, presumably drug-susceptible TB. We aimed to enroll 1,200 children under 16 years of age and randomize them 1-to-1 either to receive standard 6 months therapy or shortened 4-month course. The follow-up was the 72 weeks after treatment initiation. On the right-hand side, you can see that we used standard first-line drugs with or without ethambutol as per national guidelines. And we shortened the 4-month treatment duration by cutting 2 last months in the continuation phase. We used WHO weight bands dosing and the new at the time dispersible fixed dose pediatric formulations. Next slide. Our primary efficacy outcome was a composite and favorable status by week 72, which included TB treatment failure, TB recurrence, death of any cause, and on treatment loss to follow-up. And the trial was powered on key secondary analysis, which is very important. This is children adjudicated to have TB at baseline by an independent clinical expert, blinded to randomized arm. We assumed that we will have 80% of all children in this group. Next, please. This adjudication of TB status was based on adapted NIH 2015 consensus and included information on history of TB contact, TB signs and symptoms, chest X-ray conclusion as per central radiology review, who were also blind to treatment allocation, whether this is typical of TB chest X-ray changes or not, microbiological confirmation, and the response to treatment at 8 weeks. Next, please. We enrolled 1,204 children, 602 in each arm, at 5 sites in 4 countries in Africa and India. On the right-hand side, you can see the map where our sites were situated, and below you can see our main inclusion criteria. Next, please. In terms of baseline characteristics, median age was 3.5 years, with the majority of children aged under 6, with a range from 2 months to 15 years. 88% came from Africa, 12% from India, 11% were children living with HIV. In terms of TB forms, 2/3 had respiratory TB, just under 30% had mixed respiratory and peripheral lymph node TB, and 3% had just peripheral lymph node TB. We had 14% with microbiologically confirmed TB in the trial, and the retention and adherence to randomized duration were excellent. Among those expected to attend, 72 weeks, 95% attended, and 94% stayed on allocated treatment. Next slide. This slide shows you the main efficacy outcome. The shadow panel shows a primary endpoint in modified intention to treat population, a protocol population, and intention to treat population. And the panel below shows the treatment outcomes in adjudicated to have TB at baseline children. On the right-hand side of this, you can see that we had a small number of events in each group, and the point estimates show the difference in unfavorable status between 2 arms. You can see that all are situated around the 0 line with quite narrow confidence, 95% confidence intervals, with the upper bound of 95% confidence interval lying well clear from this pre-specified 6% non-inferiority margin. Next, please. These all analyses were very consistent and actually shows a very robust non-inferiority of 4 months treatment compared to 6 months. Pre-specified subgroup analyses were done by HIV status, region, sex, age, weight band, TB forms with or without a lymph node TB, microbiological confirmation, and ethambutol use, and all gave consistent findings. Next, please. The safety outcomes were similar in both groups. Next. Health economic analysis showed that at 72 weeks, children treated for 4 months had similar health outcomes and reduced healthcare costs compared with those treated for 6 months. On average, healthcare costs could be reduced by $17 per child, and of course applied on the national scale, this translates into large cost savings. Next, please. Let's talk about chest radiography in SHINE. Next. So non-severe TB in SHINE was defined, so children should have clinically not severely ill. And we included peripheral lymph node TB and respiratory TB. Non-severe respiratory TB was defined based on chest X-ray findings and should have been confined to one lobe with no cavities, no significant airway obstruction, no complicated pleural effusion, and no miliary TB. We had a comprehensive chest X-ray evaluation form developed by our Stellenbosch co-investigators, and you can see this form on the right-hand side. Next slide. So we were lucky at the start of the trial to have training of the trainers by Robert Gee and Megan Palmer, and subsequently our trainers trained the site clinicians. Our Stellenbosch partners also developed Shine Chest X-ray Atlas. This is a mini chest X-ray Atlas, which was a very helpful tool during the trial, which helped us to distinguish non-severe and severe TB in kids. Next slide. So chest X-ray were also retrospectively reviewed centrally by radiology experts very experienced in pediatric TB. All chest X-rays were reviewed by 2 independent experts who were blinded to randomized allocation using standardized approach. And if there were discordant interpretations, these chest X-rays were reviewed by a 3rd expert. And then the majority opinion was used, for example, in terms of severity. So the agreement between local and central reads was quite high, and in terms of severity was at 94%. Next, please. So we had only 71 kids, 6% of all children in the trial, who were considered to be having non-severe TB at the local evaluation, and subsequently were adjudicated to have severe TB at the central chest X-ray review. Of this, 10% were microbiologically confirmed, and this comparing to the whole trial, we have the 14% microbiologically confirmed, and the outcomes in this group were very consistent with the main trial. 94% had favorable outcomes, and just to let you know that in our intention to treat population, 93% had favorable outcomes. Next, please. So here you can see the little table of 4 unfavorable outcomes in this group, 2 in each group. And we had 1 death in each group, which were not related to TB. Next slide. So post-Shine, we were discussing implementation challenges, and one of them is how to make recognition of non-severe TB easier for healthcare workers. And Steve has already mentioned the Diagnostic Chest X-ray Atlas, and Megan in her talk will be talking in details about this updated atlas. And we were lucky that we were working closely with the same group of people who were working on the updated atlas. And this atlas will not only show and illustrate TB changes that we can see in children with TB, but also highlights differences between severe and non-severe TB. And infographics make pattern recognition easier. The work on computer-aided detection for pediatric chest X-ray reading is in progress, and I hope really much that it's going to make the recognition of TB in childhood and also severe, non-severe forms easier. It would be great to have accessible and interactive chest X-ray training for healthcare workers. Free interactive online training course would be highly desirable. And of course, more investments are required and political commitment to improve the access to portable digital chest X-rays in the settings where chest X-rays are not yet available. Next, please. So Shine found that 4-month treatment was good as the standard 6-month treatment for children with smear-negative, drug-susceptible, non-severe TB, and the results were consistent across all the analyses performed. Identifying non-severe TB was feasible at the sites with high agreement between local and central chest X-ray reading. Reducing the length of treatment could, of course, make treatment easier for children and families, and also reduce costs for health systems, which could be then redirected to improve TB case findings in children. Next, please. And you can find the full results of the trial in the recently published New England Journal of Medicine, which was published 2 weeks ago, with a very nice editorial and nice quick take for those who don't have time for the whole trial. Next slide. And I would like to say big thanks to all our participants and their families, our brilliant international SHINE trial team, our sponsor and the funders. And here you can see the link to the SHINE film, which actually shows you how it is for the families and our children to take a shorter treatment. Thank you.
Yeah, Anna, thank you so much for sharing these results with us. It's incredibly important trial, not only for the children and the families, as you mentioned, but also for all of us healthcare professionals who care and treat children. So I'm sure that we will all read the article and follow the trials. But now I would like to invite Dr. Megan Palmer, and she will be presenting to us the updated diagnostic chest X-ray atlas for tuberculosis in children, a guide to chest X-ray interpretation.
Many thanks for the introduction. Good morning, good evening, good day, and everyone. It's really lovely to be here, and I'd like to thank the organizers for inviting me to talk today. My name is Megan Palmer. I'm a pediatrician and a clinical researcher from the Desmond Tutu TB Center in Cape Town, South Africa, and I will be presenting the Union's updated Diagnostic Atlas for tuberculosis in children. Next slide, please. So the first edition of this atlas was published in 2003 and was written by Professor Robert Gee, who you can see on your screen. Robert is now retired, but he worked as a pediatric pulmonologist in Cape Town and really was a giant in the world of pediatric TB. He was a true teacher who encouraged critical thinking and continual learning. And before he retired, we had several discussions about chest X-ray training, pediatric TB in general, and the updated atlas. And he believed very strongly that the next version of the atlas needed to include more than just the typical well-known chest X-ray features. And we kept this in mind as we conceptualized this updated edition. Next slide. And so I now present the updated second edition of this atlas. The text you see on your screen actually comes directly out of the first edition, but really holds true for this one too. The goal of this illustrated atlas of intrathoracic tuberculosis in children is to assist healthcare workers practicing in low-income countries in the interpretation of chest radiograph in children suspected of having TB. It is not meant to replace the radiologist's or specialist's opinion, but rather should be used as an aid for healthcare workers in hospitals where there is limited access to a radiologist or specialist. And so just to emphasize those points, the target audience here is non-expert readers. So these are healthcare workers who are working in high TB burden settings, often with limited resources, and who are investigating children who are symptomatic as presumptive TB cases. Next slide, please. So key chapters from the first edition of the Atlas were kept and updated. And the role of the chest X-ray in pediatric TB outlines how and when chest X-rays are used to diagnose and manage TB in children. The section on chest X-ray evaluation in children discusses the basics of chest X-ray interpretation, gives guidance on how to assess the technical quality of a chest X-ray, both APPA and lateral, and provides an example of a systematic approach that can be used in pediatric chest X-ray evaluation. And these images here are just to give you a sense of the look of the atlas. We tried our best to use as many figures and annotated chest X-ray images as possible, with explanatory text included where needed. Next slide, please. And then we added some new chapters. These are listed here, and I'll spend the next few slides just highlighting these and discussing why we chose to particularly include these in the updated version. So you can see on the bottom right, the second edition is approximately 90 pages and could also be printed in an A5 format, like the first edition was, but is currently available online free of charge on the Union's website, and it includes approximately 60 chest X-ray images. Next slide, please. So we chose to focus, to make sure we focus sufficiently on age in this atlas, and we did this because we know the pediatric age spectrum is wide, and that this makes interpretation of chest X-rays challenging particularly for people with less experience. And so we included normal X-rays from children from different ages, highlighting what the differences are by age. We have a specific section addressing the thymus and giving descriptions of how to identify a thymic shadow on chest X-rays. And in all the included X-rays in the atlas, we made sure that we included the age of the children from whom the X-rays were taken in the footnotes of each X-ray. Next slide, please. Chapter 5 of the atlas is titled The Specific and Less Specific Chest X-ray Features of Pediatric TB. And I just want to give some context about why we decided to include this section. And I think really for most people, the biggest challenge in interpreting X-rays from children with suspected TB is the wide radiological disease spectrum. And I think we all know that children with tuberculosis can have anything from a normal chest X-ray through to destructive cavitary disease. And this makes interpretation really difficult. Approximately 5% of children with culture-confirmed pulmonary tuberculosis will have normal chest X-rays. And on the SHINE trial, 53% of the children treated for TB had either normal or non-typical chest X-ray features based on the expert consensus read. And so while acknowledging that TB on chest X-ray in kids can look like anything, we also know that by way of example, the two images on your screen do not carry equivalent diagnostic certainty, with the one on the left with airway compression and miliary infiltrates almost certainly coming from a child with TB, while the X-ray showing segmental pneumonia could be a child with TB, but could also be a child with a viral or bacterial pneumonia. And so some chest X-ray features have higher specificity than others. Next slide, please. And so in this chapter in the atlas, we classify chest X-ray features as being more or less specific for pediatric TB. And we based this very loosely on data that has been presented in these two manuscripts on your screen. Both of these manuscripts presented the sensitivity and specificity of individual chest X-ray features for culture-confirmed tuberculosis in children. And you can see in the table the features that we classify as being more specific and those that we classify as being less specific. Next slide, please. And then importantly, we included in chapter 6, we had a chapter entitled Addressing Disease Severity on Chest X-ray. And I think the context for this inclusion of this chapter has already been really well explained by Anna. We know now that children with non-severe TB can be treated for shorter, with 4 months versus 6 months, as per updated WHO guidance. This, of course, will pose a challenge in chest X-ray interpretation, as healthcare workers now need to learn how to classify disease severity radiologically. Next slide, please. And so the approach to disease severity classification on X-ray in the atlas was really guided by that was used on the SHINE trial and is consistent with what has been recommended in the WHO guidelines and operational handbook, so that non-severe chest X-ray features include uncomplicated lymph node disease. So this means there's no airway involvement, no associated unilateral hyperinflation or lobar segmental collapse, a primary gone focus. Any alveolar classification or consolidation must involve less than one lobe to be non-severe, simple pleural effusions, and non-specific features such as perihilar interstitial infiltrates. Next slide, please. And then by contrast, the severe chest X-ray features include complicated lymph node disease, consolidation involving one lobe or more, complicated pleural effusions, all types of cavitary disease, miliary infiltrates, and the less common patterns of TB bronchopneumonia or expansile pneumonia. Next slide, please. And then in addition to these classifications being presented in the text that you can see on the right-hand side, we also presented them in a tabulated format using these chest X-ray infographics, which we think makes it much more user-friendly. This table has also been sure to be able to be kept on one page in the atlas so that it can be easily printed for ease of reference. Next slide, please. And then putting it all together, we suggest using an algorithmic approach to chest X-ray classification in children with presumed TB. And I think this algorithmic approach to chest X-ray classification is familiar to everyone in the audience. And we encourage people to go through the systematic questions of first deciding if the chest X-ray is technically acceptable to read, then trying to decide if it is normal or abnormal. If abnormal, are there features very specific to TB or not? And we just need to recognize here that the features very specific to TB really do hold more weight in the diagnostic algorithm. So they really help your diagnostic decision-making more than if they're absent. If you decide to treat the child for TB, the next question is to decide whether the disease is radiologically severe or non-severe, so that this can guide your regimen choice. And throughout this atlas, we have made sure to emphasize that the chest X-ray is only part of the diagnostic puzzle, and it really should be seen as a piece of the broader diagnostic algorithms that are presented in the latest WHO guidelines. Next slide, please. These last two slides I can move through fairly quickly, but this was really just to give you a feel of how the atlas looks. For each X-ray, chest X-ray pattern or feature, we have a little table of infographics, which gives an estimate of how commonly the feature is seen in children with TB, how specific the feature is, and whether it's severe or non-severe. And then there are sets of annotated chest X-ray images. Next slide, please. And this is just a similar slide, but showing you what the page for cavitary disease looks like. Next slide, please. And then just lastly, I would like to thank everybody on this slide. Firstly, Rob Guy, who I mentioned at the beginning, who really laid the groundwork for this. It's the second edition as well. And then my co-authors, James Seddon, Simon Scarf, and Pierre Gossard, who helped conceptualize and write this with me and gave lots of technical support. The funders, the contribution from the SHINE team and the MRC CTU, who developed the chest X-ray infographics that you see here, the union team for their being very engaged reviewers to the end, and the people listed in the bottom right, who are all healthcare workers working in TB programs and gave great perspective when reviewing an early draft of this publication. The link at the bottom of the slide is where you will find the atlas, and it was uploaded today, so it is now available to download. Thank you.
Thank you, Dr. Palmer, and all the panelists for the past session here. We are short on time, but long on such very valuable information on setting the scene. I see that the Q&A box has been an active and successful, both deep and broad exchange of information relevant to many present today. So I would encourage you to continue to look at that. Because we're short on time, we will just move on to session 2, which embodies the challenges with chest radiography, to be introduced by Dr. Kasaeva Brown. Joanna?
Now I would like to invite all of you to the panel discussion on challenges in accessing the chest radiography for managing TB in children. And I would like to introduce you to the moderator of the discussion, Dr. Viney. And Dr. Kerri Viney is a team lead in the Vulnerable Populations, Communities and Comorbidities Unit in the Global Tuberculosis Program at WHO. She manages a team who lead a global TB program's work on TB in children and adolescents, TB and comorbidities, and TB in the vulnerable populations. I would like to welcome Dr. Kerri Viney to start our discussion. Thank you.
Thank you very much, Dr. Kasaeva Brown, and hello everyone. It's great to have so many people joining us online. So as mentioned, we're going to move into session 2 now, which is perspectives from stakeholders. We have 4 excellent panelists who are going to provide their stakeholder perspective on challenges with chest radiography, access, interpretation, etc. I'll just briefly introduce our 4 panelists. We have Dr. Farhana Amanullah, who is a consultant pediatrician. She heads the child TB programs at the Indus Hospital and Health Network in Karachi, Pakistan, and she's the current chair of the Child and Adolescent TB Working Group of the Stop TB Partnership. Farhana is an active clinician and researcher and was in fact a co-chair of our guideline development group. Then we have Professor Tracy Kilborn. Tracy is a pediatric radiologist from South Africa. She is the head of the Unit of Pediatric Radiology at Red Cross War Memorial Children's Hospital, and she has a joint appointment at the University of Cape Town as an associate professor. She is the current chair of the South African Society of Pediatric Imaging and the African Society of Pediatric Imaging, and a working member of the World Federation of Pediatric Imaging Educational Committee and the TB Task Team. Professor Kilborn's main areas of research are on pediatric neuroradiology and infectious diseases, and she is passionate about teaching the appropriate imaging of children, and she's actively involved in outreach to promote this. Then we have Professor Bernard Laya from the Philippines. Professor Laya is a professor of radiology at St. Luke's Medical Center College of Medicine in Manila, the Philippines. He is the head of the section of pediatric radiology at St. Luke's. He's also the president of the Philippine Society for Pediatric Radiology, the vice president for the Asia Oceanic Society of Pediatric Radiology, and the treasurer for the International Society of Pediatric Thoracic Imaging. And finally, we have Professor Harry Hausler from South Africa. He is a family physician, HIV clinician, and public health specialist with 29 years of international experience implementing and evaluating integrated TB and HIV programs. He is the CEO of TB HIV Care, an organization that provides TB and HIV prevention, diagnosis, and treatment services in South Africa. Professor Hausler is the chair of the Civil Society Forum of the Western Cape. He is co-chair of the Provincial Council on AIDS and TB, chair of the TB Prevention Task Team of the National TB Think Tank in South Africa, and he's a member of the Civil Society TB Task Team and TB Technical Working Group of the South African National AIDS Council. Professor Hausler is also a very active member of WHO's Civil Society Task Force on TB. So I will hand over to our panelists. A kind reminder that we have 5 minutes each, and please keep the questions coming into the Q&A box, and we will do our best to respond to those as the panelists are speaking. Thank you very much.
Thank you very much, Kerri, for the introduction, and thank you to the organizers for having me present challenges from the field. So I'll be speaking on challenges in access to chest radiography from a high burden setting. Next slide, please. So using the search, treat, and prevent strategy, the childhood TB program in Pakistan was implemented a strategy whereby, which was also known as the Zero TB Cities Initiative, and there were child TB clinics that were set up in various parts of the city. And this slide essentially shows really the power of screening children for symptoms and then further evaluating those found to be presumptive. As you can see, there were many children who were diagnosed in the program, and particularly and chest X-ray was one of the key diagnostic modalities that was used in diagnosing pulmonary TB. Next slide, please. So again, this is a paper from the same program that was published in 2019. Here also, I just wanted to point out that of the 1,600 children who were diagnosed with TB, the vast majority were children with pulmonary TB, 75%. And here you can see, again, using chest X-ray as a main diagnostic one of the diagnostic modalities, and intensified case finding resulted in the diagnosis of finding 55% of the children that were diagnosed with TB in this particular cohort. Next slide, please. So in terms of challenges, when we're setting up the program, there were sites that did not have any chest X-ray facility available. There were sites that had chest X-ray available, but was not free and hence was not accessed by many. There were chest X-ray services available, but were of poor quality. They were and when we were able to implement mobile chest X-ray vans, there were times when there was no one available. In fact, most of the time when no one was available to interpret the chest X-rays that were taken in the van. Next slide, please. So to overcome these challenges, of course, we had medical officers who were trained and installed in each of these sites, and they're shown in the picture on the left. Again, the atlas that was just presented will be a fantastic boon to such trainings, as it gives very focused chest X-ray training pertaining to tuberculosis. That'll be an excellent update, and thank you for that. And on the right is a mobile chest X-ray van, which has SCAT4TB technology in it. We are lucky to have that. However, this was only would only read X-rays for 15 years and above. The digital chest X-rays that were taken for children were then interpreted by radiologists, but they had to be interpreted by a radiologist or a medical officer. Next slide, please. So challenges remained despite linking children with diagnostics. So I was bombarded with a slew of images that looked like this. A lot of them were very difficult to interpret because of the quality, because of the fact that there was no proper backlighting, and there were numerous challenges. If I would bring this to a radiologist, they would just shoo me out and just say that, you know, we will not commit to reading such X-rays. Next slide, please. Again, more hard to read images, but you can see that the X-rays are definitely not normal. They're quite abnormal looking X-rays. Next slide, please. Again, I mean, we had all sorts of things in the background of those X-rays. It was a really hard task to try and, you know, interpret these X-rays. So that was a major challenge. Next slide, please. And then there were images from the mobile chest X-ray van, which were, again, there was no one to read them, but as you can see, several of these X-rays had significant findings on them. And again, it was worrisome that some of these children were actually being screened and may have been missed in the health system, and they had significant disease. The other challenge was that, you know, what if this is something other than TB? And then linking these children to further imaging and further testing was another programmatic challenge that we had to deal with. Next slide, please. So this is from the Delft CAT4TB website. As you know that at this point, CAT4TB and AI-assisted reading is not recommended yet for children under 15 because more data is needed. And however, it seems that they have the CAT4TB6, which apparently is reliable for children up to 4 years of age. So this is fantastic, and this is something that we are eagerly awaiting. Next slide, please. And this is again a reminder that tools for screening for TB for 15 years and above are clear and the modalities for screening children who are in contact with TB are also clear and have chest X-ray included in the algorithm. Of course, it depends on the setting and the availability of the technology and the ease with which that can be implemented within the country's algorithm. Next slide, please. So in summary, there were many challenges around quality of chest X-ray in high burden settings, around access to quality chest X-ray in high burden settings, particularly at the community level. There were local innovations can bridge some of these gaps. Intensified screening using digital technology and AI assistance is a definite way forward as it overcomes the barrier of you know, having a human read the X-ray as well as the quality issue. Of course, we need more investment, definitely domestic investment, private sector and civil society engagement, and ongoing donor support to reach our child and adolescent TB elimination goals. Thank you very much for your attention.
Okay, Professor Kilborn. Thank you, Farhana.
Thank you. I'm just waiting for my slide. Thanks so much. So I'm a pediatric radiologist in a fairly fortunate position in that I'm in a tertiary quaternary hospital. So we have access to radiologists and also access to radiographers or technologists that are skilled in imaging children. So what are the issues? I think they have been spoken about before, and for the issue of time, I'm going to try and limit my slide to this one slide. What are the problems that we have in Africa? Well, these have already been mentioned. So equipment quality, I would say one of the main issues that we've noted is maintenance. A lot of times these images are purchased, but without maintenance agreements. So when the machine goes down, there isn't money to repair them, and that leads to interruption of care, in that then patients have to go to other clinics that may be further away and therefore may actually choose not to access healthcare. Technologist skill, I'm thrilled that Megan has put this into their atlas. It's one of the biggest problems with imaging children, as you know, and particularly in interpreting chest x-rays. For those healthcare practitioners who are not used to looking at children's x-rays and not knowing how rotation and a poor inspiratory projection can really affect the quality and make pathology there that doesn't exist. As a pediatric radiologist, I am always worried about dose, particularly when images are being done in areas where technologists are not used to imaging children. And we are seeing increasingly coming from peripheral clinics, very high doses that you would use for adults, and it's not really acceptable. So maybe that also needs to be looked at. I'm not sure whether that is brought up at all in the atlas, or whether it needs to be brought up at a WHO level in terms of recommended doses for children. I've talked about the quality, the interpretation. Again, I think the atlas is outstanding in that it is saying that one needs to look at quality before you start interpreting. We find that with a lot of the patients that come to us, the chest x-rays are poor, and therefore they've just been called TB because something's been seen on the x-ray. And then failure to follow guidelines or seek advice. Again, you've addressed this in your SHINE trial and in the chest x-ray atlas, which I'm thrilled to see. And then really access to additional imaging. So what is the role of ultrasound? We found it astonishingly difficult to try and interpret this and bring it into routine chest practice. I think it may have a role in the future, but it's not going to replace chest x-ray. And then the role of point of care ultrasound for abdomens if you suspect disseminated TB. So I think I've managed to do it in 3 minutes. But yes, access to care, I think it's about the actual quality of the x-ray as well as the interpretation. Thank you very much.
Thank you very much, Professor Kilborn. We'll move to Professor Laya. Martina, can we move to Professor Laya's presentation, please? Thank you. We have no audio, Martina, just letting you know at our end that there is no audio.
Sorry for that. One moment.
No problem. Thank you.
Good day, I am Bernard Laya and I am from the Philippines. The Philippines is a country in Southeast Asia located west of the Pacific Ocean. The population is estimated at over 110 million. So it is a very young population, and about 34% are children aged 14 years and below. The country is categorized by the World Bank as a lower middle income country. And TB is highly prevalent in the Philippines, and approximately 1% of the population has tuberculosis. As a result, it is the number 5 cause of death in the Philippines, and approximately 74 Filipinos die of the disease every single day. chest radiograph may not be the perfect imaging tool for the evaluation of childhood thoracic tuberculosis, but it remains very helpful for screening, diagnosis, evaluation of the extent of disease, aid in clinical management and treatment algorithm, follow-up during and after treatment. And of course, we know that there is wide spectrum of findings in childhood thoracic TB on chest radiograph, ranging from lymphadenopathy with or without lung disease, progressive lung disease, destruction of the lung, and even disseminated or biliary pattern. We all know that the COVID-19 pandemic has posed significant challenge, particularly for TB diagnosis and treatment. There has been significant reduction in case detection and reporting, and this is because people are less willing and less able to seek care, particularly during lockdowns and restrictions. As a result, there is increase in the number of people who died from TB in the year 2020. Much like any other developing country, financial resource and its impact to the country's TB program is very important and is a challenge in itself, because the TB program already is underfunded to begin with the private, local, and international funding. It's still not enough. Therefore, the facility and equipment are limited, particularly in rural locations and provinces. Human resource is also a problem. In a country where there is 110 million population, there are only about 2,000 practicing radiologists and much even fewer pediatric radiologists. We continue, however, despite the restrictions, the challenges, we thrive and we continue our pediatric radiology fellowship program because we understand the limitations between adult and pediatric imaging, and we also understand the importance of having trained pediatric radiologists when you actually diagnose imaging studies for childhood tuberculosis and other pediatric diseases. For the last several years, we were able to organize and form the Philippine Society for Pediatric Radiology, and we are now a allied subspecialty of the Philippine College of Radiology. We all know that chest radiographs have inherent limitations, particularly due to its low sensitivity and specificity and high inter-reader variability. Detection of lymph nodes or lymphadenopathy could be difficult in chest X-ray, and therefore the lateral radiograph may help increase the accuracy. But despite of this, there are instances where we have to resort to advanced imaging studies such as ultrasound, CT, or even MRI. We should not be too quick calling nodal calcification or lung calcification as a sign of healed TB, because this may not necessarily be so, particularly if the child was never treated for tuberculosis. Also, the terms such as primary complex, infiltrate, pneumonitis are quite rampant in chest X-ray reports in my country, particularly when it comes to childhood tuberculosis. But these are not standardized terminology and may mean different things to different people. Also, there is limited clinical correlation of the imaging studies. Therefore, we were actually, with the help of the international colleagues and also the World Federation of Pediatric Imaging, we published standardized radiographic interpretation of thoracic TB in children. And this was published in Pediatric Radiology Journal. But of course, we are looking forward to the release of the international guidelines on radiographic interpretation of childhood TB released by the World Health Organization. Thank you very much for your attention.
Thank you very much, Professor Laya. And we'll move to Professor Hausler. Thank you.
Thanks very much. I see that my image is not very clear. I'm not sure why. And unfortunately, I don't have a slide deck. I'm wondering if I should change my background, but I'll just apologies for this. Let's see if that. Yeah, I just have to be closer to the camera. Here we are. So thanks very much. Yes, thanks for the introduction. Thanks very much for the previous speakers. I am representing the Civil Society Task Force on TB that has members from around the globe. And I consulted with the other members of the task force. And one item that was raised by a colleague in Kenya was that still in Kenya, chest X-ray is not free to children under 15 and is inaccessible as a result of the cost, with up to $15 per X-ray. And then from the colleague in Pakistan, a concern about over-reliance on digital radiography in settings where there's no access to it. But I do just want to reflect on the global statistics. We heard that there were just over 1 million people with children who were estimated to have TB in 2020, but 226,000 deaths in children. That equates to 619 per day, or 52 children dying in the 2 hours that we are going to be attending this webinar. Children are 11%, make up 11% of the global TB burden, but 15% of the deaths. But these deaths are preventable through early diagnosis and also through prevention. So we heard that there's enormous underdetection of TB, with only 27% of children under 4 who are actually diagnosed. But the prevention gap is enormous, with 2/3 of eligible children not having access to TB preventive therapy. So I do want to reflect also on the personal impact on children themselves who may have to stop their schooling, and on families, the mental health impact and the psychosocial impact of having TB. So civil society therefore welcomes the new guidelines from WHO, as well as the Diagnostic Radiology Atlas from the Union, because they offer a consolidated guideline to improve diagnosis of children in different settings with access to different diagnostic modalities. Also, the shorter regimens are very welcome for children to decrease to 4 months, and the all oral regimens is an issue that the Civil Society Task Force has really been calling for any person with drug-resistant TB, including children. Just personally, I'd like to reflect on my work in TB/HIV care in South Africa, because we do provide support to children who are hospitalized and their families. And you can imagine if families can't afford to go and visit their children, they only get to see them once a week. They don't even have funding for transport. So we do provide transport support to the families to visit their children, and also we provide educare teachers within the hospital setting. But the most important element for me is that we can prevent TB in children. So if we invest in communities to end TB, and if we have a community-based approach for educating people about symptoms, and then doing household contact tracing and access to TB preventive therapy, we will have a much better outcome in terms of the epidemiology of TB and to decrease the impact on families. So there are challenges in terms of access to digital or to chest X-rays, and many clinics don't have X-rays, so children would have to be referred to a district hospital to access the X-ray. So as much as we can provide point of care kind of diagnostics or algorithms that aren't dependent on X-rays, the better, but also increased access to radiology is important, as we've seen in the diagnostic algorithms. So I do also welcome the work that's being done to increase access to mobile X-rays and digital radiography, and the work on computer-assisted diagnosis of TB. We know that it's not yet recommended, but it's urgently needed so that we can actually make diagnosis, screening and diagnosis through radiology more accessible to community members and to the families. Just the last note was that at this World TB Day event I attended, I heard a story from a senior medical officer whose father had delayed diagnosis of TB and died at the age of 45. And he, as a child, developed TB. He had no access to TB preventive therapy, and he ended up hospitalized for a month at the age of 4.5 years. This can be prevented if we invest in communities, and we have community health workers who educate communities about the symptoms of TB, ensure that adults are diagnosed early, and that all contacts have access to TB preventive therapy to prevent TB in the first place. But if children do become sick, that we also have to invest in access to the molecular diagnostics, as well as access to radiology, and train healthcare workers to interpret those codes. Thanks very much.
Thank you, Professor Hausler, and thank you to our 4 panelists for those perspectives. We're a little bit behind time, so we're going to move straight into the next session, which is perspectives from the professional bodies. And we have 5 panelists, again, with 5-minute interventions. I'll just briefly introduce our panelists. We have Professor Tarek El-Diasti, who is a professor of radiology, former chairman of the radiology department at the Urology and Nephrology Centre, Mansoura University. He's the president of the African Society of Radiology, president of the Egyptian Society of Radiology and Nuclear Medicine, and a member of the executive committee of the International Society of Radiology. Professor El-Diasti contributes to global efforts to improve access to high-quality imaging in low and middle-income countries. Then we are joined by Professor Kushaljit Singh Sodhi, who is a paediatric radiologist based in India. He's currently working as a professor in the Department of Radiodiagnosis at PGIMER in India. Professor Sodhi is currently also heading the TB group of the World Federation of Paediatric Imaging, who are one of the co-hosts of this webinar today, and he's one of the executive council members of the World Federation. He's also the current treasurer of the Asian Oceanic Society of Paediatric Radiology and Secretary General of the Indian Society of Paediatric Radiology. He's the immediate past vice chairman of the Indian College of Radiology and Imaging, and is a member of the Thoracic Imaging Committee and a member of the American College of Radiology Practice Parameters and the Writing Committee. Then we're joined by Mr. Stuart Whitley. Mr. Whitley qualified as a radiographer in the Royal Army Medical Corps in 1967 and then qualified as a teacher radiographer at the Royal Victoria Hospital, Belfast. Mr. Whitley is a fellow of the College of Radiographers, and he's held several roles in the radiography profession. This year, as part of the Society of Radiographers centenary celebrations, he was awarded a gold medal for his services to radiography. We're also joined by Mr. Francesco Ribolzi from Italy. He is a biomedical engineer with a master's degree in international cooperation and planning for development and postgraduate qualifications in public health. Mr. Ribolzi has more than 20 years of working experience in the health sector and at least 15 years in low and middle income countries dealing with public health programs. Over the last 3 years, he has worked for the Italian Cooperation Agency as a health program manager based in Jerusalem for UN Ops, and he is working with the Southeast Asia Hub. Since May 2020, he's also been working as a senior biomedical engineer consultant for WHO headquarters in Switzerland. And then finally, we're joined by Professor Vijay Yawale from the International Pediatric Association in India. Professor Yawale is the head of the Institute of Child Health, Apollo Hospitals in Mumbai. He is the past president of the Indian Academy of Pediatrics, editor of the Textbook of Pediatric Infectious Diseases, and editor-in-chief of Pediatric Infectious Disease, the journal of the IAP Infectious Diseases chapter. So I would like to hand over to our 5 panelists. Again, if we could just keep the interventions to the 5 minutes allocated and be quite brief, that would be much appreciated. Thank you very much. I think we're starting with Professor El-Giasti. Thank you.
Thank you very much for the kind introduction. I'd like to thank all organizers for this opportunity, Radiology, and the World Federation of Pediatric Imaging. Dear colleagues, ladies and gentlemen, I would like to thank all organizers and contributors from the WHO, the International Society of Radiology, and the World Federation of Pediatric Imaging. World TB Day is an opportunity to raise awareness about the burden of tuberculosis worldwide and the status of TB prevention and care efforts. It is also an opportunity to mobilize a political and social commitment for further progress in efforts to end TB. In 2016, 2.5 million people fell ill with TB in the African region, accounting for a quarter of new TB cases worldwide. An estimated 417,000 people died from the disease in the African region out of 1.7 million globally. So over 25% of TB deaths occur in the African region. TB can affect everyone, but children and young adolescents are particularly vulnerable. They accounted for 11% of 10 million people who fell ill with TB in 2020, and sadly, over the quarter of a million children died. Many countries have not fully scaled up and implemented screening tools according to WHO recommendations. Choosing an accurate systematic screening algorithm is critical, and there are specific considerations involved, including how well the screening and diagnostic tools perform in the population to be screened, the trade-off between the risk and benefits to the person being screened, the ability of the screening algorithm to detect TB without risking over diagnosis, and the feasibility and costs. The WHO guidelines of systematic screening for active TB include principles and recommendations that are followed in many countries in North Africa, including Egypt. These guidelines describe a symptom screen as the initial test and the use of chest X-ray as the initial screening test. If symptom screening is used initially, then chest X-ray can be used as a second screen to improve the pre-test probability of the subsequent diagnostic test and to reduce the number of people who need to undergo further diagnostic evaluation. A review of prevalence survey of 23 countries in Africa and Asia showed that 90% of people with bacteriologically confirmed TB were detected through the use of chest X-ray, highlighting the important role chest X-rays could play for TB screening in view of the limited sensitivity of symptom screening. Chest X-rays, however, have not been feasible to implement on a large scale in systematic screening programs in our region because X-ray machines are generally costly and bulky, and because many low and middle income countries don't have sufficient access to trained radiologists to read and interpret X-ray images. These barriers to implementing chest X-rays on wider scale may soon be reduced with the development and scale up of lightweight portable X-ray machines for use at the community level and the use of computer-aided detection software to assist health workers in reading and interpreting X-ray in decentralized health settings. Computer-aided detection utilizes artificial intelligence, deep learning networks to identify lung abnormalities suggestive of TB on chest X-ray images, with a number of studies showing that CAD has comparable performance to trained human readers. These new tools could help to fill a critical gap for TB screening and triage by making chest X-rays more feasible to implement on a large scale at or close to the point of care in low and middle income countries. The increased use of chest X-ray combined with CAD as a screening and triage tool could also help to target and optimize the use of more expensive rapid molecular tests, extending the reach of diagnostic system and health budgets. The WHO has been reviewing CAD tools as a class of technologies and will release updated WHO guidance on the management of tuberculosis in children and adolescents in this meeting. I would like to finish my talk by promising statements. Globally, an estimated 53 million lives were saved between 2000 and 2015. And 10 million lives were saved in the African region between 2000 and 2014 through TB diagnosis and treatment. The incidence is falling at about 2% per year. This needs to accelerate to 4 to 5% annual decline to reach the milestone of the end of TB strategy. Ending the TB epidemic by 2030 is among the health targets of the newly adopted Sustainable Development Goal. And thank you so much for your attention.
Thank you, Professor El-Diasti. We'll go to Professor Sodi.
Thank you. So I can start by saying that the World Federation.
Professor Sodi, it's a little bit hard to hear you. Can you come a bit closer to the microphone?
Hello, am I audible now?
Please speak. Let's see if we can hear you.
Okay. Yes, the World Federation of Pediatric Imaging, as I was saying, we have a tuberculosis group.
Professor Sodi, I'm sorry, it's not audible.
Okay, just a second.
Hello. Do you have a headphone? Yeah, that's better. Thank you. Please go ahead.
Okay.
Thank you.
Some issues with the mic, I guess. Okay. So the World Federation of Pediatric Imaging has a tuberculosis group. We have members across the globe, and we have dedicated lectures and study material on imaging of pediatric tuberculosis on our website. So, can I go to the next slide, please?
Professor Sodi, I'm so sorry, but we can't hear you.
Hello.
We could go to, Please try again.
So is it audible now?
Yeah, I'm afraid we can't hear.
Okay.
Perhaps we could go to the next speaker and you could check and we'll come back to you. Would that be okay?
Yeah, that's okay. Sure.
Thank you very much. And if you could just check in the meantime, thank you. We'll go to Mr. Whitley. Thank you. Sorry about that, everyone.
Thank you. Good afternoon, good evening, good morning, everyone. I'm Stuart Whitley, Director of Professional Practice for the ISRT, and a big thank you for being offered the opportunity to share this afternoon our thoughts. I'm also, from a personal perspective, delighted to share, as my mother, as a young lady, suffered from TB, and I can remember as a young boy accompanying her as she attended the Belfast TB clinic for her regular checks, and it was back then that I became interested in radiography. As you learned today, radiographers have an important role, and I hope in my talk will give you a quick outline of our perspectives. Next slide, please. There are many challenges in terms of access, and my colleagues in Africa give me some of those input, as you can see on the screen. And I don't want to, for the sake of time, read everything, but everything would appear to be quite variable. In Nigeria, they have built on what they used to do in the past and created infectious hospitals where they will treat TB and AIDS. But the equipment is not necessarily in all of those institutions. And in the UK, we have a regional system, certainly in the Northwest where I work, it's a virtual system. And we have specialists, pediatric specialists, and nurses which look after this particular issue. So next slide, please. Equipment considerations. At the moment, we have a choice of digital radiography, direct digital radiography, CR, or film processing. We can either have a conventional room design or an ultra-portable digital solution, but we've got to remember we need to consider PACS and risk considerations, the infrastructure behind that, workstations, radiation protection considerations, including PPE and shields, as we've heard already, the use of artificial intelligence. But importantly, when dealing with children, we need a lot of accessories such as foam pads and child-friendly distraction toys and aids, plus markers. And it's important that we have quality test tools to make sure that our equipment is continuing to operate effectively, as well as maintaining it, as we've just heard. Next slide, please. Now, radiographic technique is really key to good diagnosis. So we need a consistent approach. The technique will be dependent on the age of the child and their cooperation. Ideally, we need dedicated pediatric radiographers who have an understanding how to deal with children. And here are some good examples of the radiographic technique. Good cooperation needs to be established, and we need to have the trust of the child, because we want to make sure that they do make that breath, that fill their lungs whilst we make the exposure. Now, PA chest is preferable, and also for children under 6 use an AP. Here I've given a detailed discussion of how we would operate and conduct a chest X-ray on a child in the AP position. I should have put AP after the position of image receptor. But the important thing to stress is the position of the patient and image receptor, and also the direction and location of the X-ray beam. All of that needs to be standardized, and we need some sort of formal book to put all of that in. Next slide, please. we mustn't forget exposure factors and diagnostic reference levels. Exposure factors will be much dependent on what type of image receptor we're actually using. And they will vary between the different types of image receptor. I've given some examples of the KV range and MAS and FFDs that we will use on a DR machine. But equally important, we've got to establish local diagnostic reference levels, which will be based either on age and weight, and either be area products on entrance doses. So we need really to establish that and have a consistent idea as to what the radiation burden to the population is as well. And of course, there are some excellent European materials on the European guidelines on the DRLs and pediatric imaging. Colleagues can look at. Next slide, please. Now, we need consistent high quality images. And here we can see a couple of images from Manchester Children's Hospital. And you see one is done in the erect position and the other one in the supine position. But here I've outlined some of the important characteristics that the radiographer or whoever's taking the image should be checking before they pass that on for the radiologist to actually interpret. Right. I wanted to say an awful lot more, but because of time, I'm going to cut it short there. But I'd like to thank everybody for the opportunity to share this afternoon. I'm quite happy to share these slides. Just drop me a line, please. Thank you.
Thank you very much, Mr. Whitley. It's great to have your perspective. We'll go back to Professor Sodhi, and hopefully the sound is working. Professor Sodhi, back to you.
So am I audible now?
Not really, no. Can you try again, please, Professor?
Yeah, is this better?
No, I'm sorry, it's not audible. We can keep going and we'll come back to you.
Yeah, okay.
Yeah, perhaps if you try to join from a phone, a mobile phone, that might help. We can come back to you. Yeah, I'm afraid it's not audible at all, almost. So we will come back to you, Professor Sodhi. Let's go to Mr. Ribolzi. Francesco, please go ahead. Thank you.
Hi, everyone. Hi, everyone. Good morning, good afternoon, good evening, everyone. So now I would like just to give you a perspective of what WHO, together with the International Atomic Energy Agency, has developed for portable and mobile digital radiography system technical specifications for adult and pediatrics. So next slide, please. These are the recent WHO publications, but we have also seen something from the previous panelists. So next slide, please. I would just focus mainly on a couple of technical documents that are the one developed and published in November 2020. That is a document published with the WHO in collaboration with the IAEA, and this is mainly related to the technical specifications for COVID-19 devices, including the imaging equipment, so including ultrasound, mobile X-ray for chest X-ray and CT scan. And then next slide, please. Another document just published in August 2020 is the one related to the development and publication of the technical specifications for portable radiography, portable digital radiography systems. So next slide, please. The methodology used, we started from the existing products on the market and the analysis of international and regional and country standards, and all a landscape of the new products linked to the computer aid technology and artificial intelligence. Then we created a panel of experts from WHO, jointly with the International Atomic Energy Agency, and we developed the requirements. Each requirement discussed in this panel by this expert. Then, once we drafted the final document, this document has been shared externally with external stakeholders to receive informations, comments, and these comments has been included in a second review in order to create the final technical document. Next slide, please. The main target of these technical documents is to support the decision making and the selection and the allocation of use, so the diffusion of these portable and mobile X-ray systems in order to improve the diagnostics potential. The intended use is for procurement and regulatory agencies, also healthcare providers and managers, as well as policymakers and planning officers, but also to inform on the minimum requirements requested by the technical point of view, try to inform also biomedical engineers and professionals, medical physicists, private and health sector, and all the other intergovernmental and other organizations. Next slide, please. The focus on the clinical issues are mainly, but not exclusively, related to the tuberculosis screening and triage of this technical document for chest X-ray, also trauma management and pneumonia and COVID-19. But the minimum requirements developed that are focusing on these clinical issues can be better tailored to specific intended use and purposes depending on the beneficiary's needs. Next slide, please. So this is at the every technical specification document that you will find in our publication is divided in different sections. So this section, this is the example of the portable X-ray. The sections are mainly related to the names, purpose of use, technical characteristics, physical characteristics, utility requirements. Next slide, please. And the accessories, consumables that are needed, packaging, training, and so on, warranty, arriving to the decommissioning and safety standards. Next slide, please. So each technical specification section is divided in subsections, and in this case, for example, the technical characteristic sections for the portable X-ray details every single requirement related to the X-ray generator, the generator stand, the X-ray detector, the detector stand, the portable PC workstation, the software, hardware, the case, and the accessories. What is not including this technical specification is the CAD technology, is the specifications related to the software for computer aid detection technology. So next slide, please. When I was talking about minimum requirements, I was just focusing on the fact that we have the possibility in the document that you will see to better tailor, better target our technical requirements that are the minimum to different clinical use. As you can see, this is just an example of the X-ray generator. You see in brackets, we have the minimum requirements defined by us, and then in brackets, some suggestions focusing on potential improvements and changes. Next slide, please. I'm going to conclude. You can find all the publications and all the technical documents downloadable in Excel formats. So the most of them in our priority medical devices information system that will be uploaded to the last version this month. So, and they will be online for free. So thank you everyone, and over to you.
Thank you very much, Mr. Ribolzi. We will go back to Professor Sodhi, who has joined on a different device. So I'm really hoping that the sound works for Professor Sodhi, and apologise, we have gone a little bit over time. We will just move through the final panelists and then conclude. Thank you. Over to you, Professor Sodhi.
Thank you so much. I hope I'm audible this time.
It's really good. Thank you very much.
Thank you so much. It's okay. Can I have my first slide? So I'm going to concise in one slide now. On behalf of World Federation of Pediatric Imaging, we have a focused tuberculosis group, which I'm leading at the moment. So we have members of tuberculosis group across the globe. So we help in reading and diagnosing the cases of tuberculosis across the globe, specifically in areas where there might not be any pediatric radiologist available for reading the chest x-rays or other imaging modalities required to diagnose or exclude tuberculosis specifically. So we have a focused WhatsApp group now as well to decrease down on the reporting of this pediatric tuberculosis chest x-rays. And we have our own World Federation of Pediatric Imaging website in which there's a TV section in which a lot of information, lectures, webinars, and PowerPoint presentations are available on reading and diagnosing tuberculosis in children specifically. All right. Thank you.
Thank you very much, Professor Sodhi. And the link is there for people who want to visit the site. And we will finish with Professor Yawale. Please go ahead. Thank you.
Good morning, good afternoon, good evening, and thank you so much for having me. I'm a pediatrician basically, and we look at these challenges in accessing a good quality chest radiograph. And this is very important on the background of the new recommendations of shorter duration therapy.
Professor Yawale, I'm very sorry. Can you please just come a little bit closer to the microphone? So it's just a little bit soft.
Is it better now?
That's a little bit better. Thank you very much. Thank you.
So I was saying it is even more important to look at these challenges in accessing a good quality radiograph, especially on the background of the shorter duration recommendation in non-severe TB, where diagnosing and categorizing a pediatric TB as non-severe TB could be a big challenge. Can I have the next slide, please? We know that access to chest radiography has been a big challenge in low middle income country. I'm from India, and if you look at our public health system and the numbers that we deal with, X-ray facility, it is not really feasible to have good quality X-ray equipment in the peripheries. Many smaller towns, they use 30 to 50 mm machines, and to obtain a good quality X-ray on such small machines, in a pediatric patient is really a big challenge. As such, to get a good frontal view in inspiration of a young child is very difficult. And even if one manages to get a reasonably good quality X-ray, access to quality interpretation is again very difficult, especially in peripheral small areas. Unfortunately, with due respect to the radiologist, there is somehow declining interest among the new generation radiologists in learning conventional radiology. They find CT scan, sonography, MRI more lucrative. Can I have the next slide, please? Digital radiography we have been talking about, although not available at this point in time in many places, it adds to the difficulty even further. The digitally clicked X-rays are given us in print form, hard copies are sent out. The radiologist who deals with digital radiology would process the film as per his or her understanding. There's very little clue many a times, unfortunately, there is no clinical background given to the radiologist. And this digital radiology films, which are given as print, can't be processed by the reader or clinician, and the interpretation could be faulty. Next slide, please. However, the X-ray chest is an extremely important tool in the algorithm that has been recommended. It definitely gives you a probable diagnosis, especially in the paucibacillary pediatric tuberculosis. However, what is recommended generally is microbiological confirmation as far as possible, especially the advent of newer molecular platforms like GeneXpert and Ultra. However, most of the pediatricians across the country have been tuned and trained to make a diagnosis based on clinical symptomatology, the TST, which is no longer available now, of course, and the X-ray findings. And there's a lot of intra and inter-reader disagreement. Very often it is under or overdiagnosed, compounded. The problem is compounded further by poor quality film, and somehow asking for a repeat film is it's a difficult task. And having made a diagnosis based on X-ray chest, very often the treating clinician does not make any attempt to pursue molecular or microbiological diagnosis. And this is going to be a problem, especially in areas where there are pockets in our country where the multi-drug resistant tuberculosis is a huge issue. It's an increasing problem. X-ray chest, yes, it's an important tool that would definitely, if placed properly in the algorithm, would improve the yield to efforts in when one resort to asking for tests like CB-NAT, Gene Expert or Ultra, or smear to confirm the diagnosis. So I thought these are very candid admissions and challenges that all of us face in our country. I would stop here. Thank you very much. Thank you for the opportunity.
Thank you very much, Professor Yawale, and thank you to the 5 panelists for this session from the perspectives of professional associations. We're over time, so I will hand back to the chairs, but thank you.
Thank you, and I will start here. Because of time, we will conclude this symposium on guidelines on the management of pediatric tuberculosis, focused on the role of radiography. I would like to thank all content experts, especially the administrative support for this joint World Health Organization, International Society of Radiology, and World Federation of Pediatric Imaging Symposium. And to you, especially as attending, you are participants active in amplifying what was discussed today in improving the care of children in the setting of tuberculosis. I invite now concluding comments by my distinguished co-chairs, first Dr. Kasaeva Brown, and finally Dr. Mabunga.
Yes, I would like to repeat after Professor Down that it was an excellent symposium, and reading all of the comments, I hope that you all found it very, very useful and helpful. And I would like to say thank you to all of the participants who gave the time and energy, and especially people who are involved in writing the new TB guidelines and involved in the SHINE trial, because all of your work, it's really important for all of us looking after the children, for pediatricians, radiologists, radiographers, and everyone who is involved in the care of the little patients. So thank you very much from all of us.
Okay, thank you so much. Also echoing the comments that this has been an excellent discussion. Also, I would like to appreciate my co-chairs, as well as the collaboration with the International Society of Radiology and the World Federation of Pediatric Imaging. I also would like to acknowledge, because this work also involves collaboration with the Department of Environment, Climate Change, and Health, particularly the Radiation and Health Unit within WHO. So on behalf of the directors for those respective departments, Global TB Program, and the Department of Environment, Climate Change, and Health, I would like to express our appreciation. And I think my colleague Maria is on the call, who has also been very active in supporting this, this work. So thank you all to the speakers, panelists, the co-chairs, but also to all the colleagues who've been working behind the scenes, not only for the symposium, but for all the work that provided inputs into the discussions that we had today. So thank you so much. Back to you, Donald.
Wonderful. Thank you all again for making this such an enriching and educational symposium. I think I learned more than anyone else here today. So with that, we'll close the session. I wish all of you a great day and continued support in all you do for the care of children. Thank you.